Just down here.
Yep.
Okay. And then do you want the slideshow?
Yes, please.
Do you do just this one?
Yeah, from beginning. There you go.
All right.
These controls, if you need to swipe that up out of the way too, can you hit hide or
Do you want me to just hide them for you?
Whatever works for you. I don't think I have anything that's at the top. of this.
like
Right.
hide video panel or meeting controls? Oh, all right.
Bam.
Great.
There
Okay.
you go.
Thank you
Ready?
guys for coming. I'm gonna see. I think most of us have met at this point. Sleep or not doing at this point. So I was given the topic of physiological effects of surgery on the body, which is a very broad topic. So this is going to be about a 15-20 minute overview, and then we can kind of have a discussion if you guys want to. I wouldn't be a good anesthesiologist without talking about the effects of anesthetics and how they can kind of counteract a little bit of what surgery does to the body. So at this point, we have gone well beyond the surgery without anesthesia part of our unfortunate history in this country. And you already saw my little icons here, I think, but I was just gonna.
If you go down to your bottom left.
Oh, there we go. Oh, this is just very slow.
Okay.
So I have these little icons here because it is going to be both a 30,000 foot view in certain aspects and also a very microscopic view looking at a couple of the things from kind of cell biology and, very basics of biology that we all did in college or professional school a long time ago. So for our outline, here's a picture of Grey's Anatomy. Various effects of surgery. I'm going to go over kind of the stress response, endocrine response, some immunologic pathways, then pain pathways, and then basically summarize that they're all interconnected. Your hormone, the stress is causing your hormones to kind of go out of whack and your immune system to kind of go out of whack. So we'll kind of talk a little bit about that and how they interplay. And then the effects of anesthetics, we'll just do kind of volatile anesthetics and propofol. I'm not talking about opioids or any of the other adjuncts that we use because that would be probably too broad of a topic to go over. So to start off, talk about the stress response. So our sympathetic nervous system, which I have in this little chart over here, just as a kind of a reminder of what the general effects it has on the body. It really is activated in response to hypotension or just general inflammation from surgical stress. So, once the surgeon cuts into the body, causes localized inflammation at the site of the surgery, and then hypotension, obviously, from a number of factors, whether it's blood loss, low volume, or just from, the anesthetic induction. So that then triggers the paraventricular nucleus, so PVN, which is in the hypothalamus, to then activate the posterior and anterior pituitary to start kind of secreting hormones, which we'll go into on another slide. At the same time, the limbic system is directly stimulated by this inflammation and acts via the amygdala and brainstem nuclei. At the same time, the adrenal medulla, so a big part of the adrenal gland, which secretes catecholamines, so the norepinephrine, the epinephrine that we give, hopefully not that frequently in the PACU, but we give a fair amount intraoperatively. Those endogenous catecholamines, so the ones that our body makes, are secreted by this kind of response from the sympathetic nervous system, all triggering tachycardia, hypotension or hypertension. Sorry, that's a mistype. Metabolism, catabolism. Want to break down sugars in our body, break down those stores so we can finally use them and fight. So again, this is the fight or flight response, which again triggers this gluconeogenesis, glycogenolysis. Basically, we want more sugar in the body so that we can use it for whatever we need to be acting up against, which in this case is surgery. Here, I thought was a really good reminder that I needed to look at because I'm supposed to know all of these things, I think, about the various receptors that both norepinephrine and epinephrine work on and the effects that they cause. So with the alpha receptors, alpha 1 and alpha 2, and then beta and beta 1 and beta 2, which I'm not going to quiz anybody on here, but I kind of already mentioned that the anterior and posterior pituitary are activated by the hypothalamus in response to the surgical stress. But it also is activated a number of other ways. We talked about the adrenal cortex, the adrenal medulla. Adrenal cortex is also activated to secrete cortisol. So at the same time we're producing norepinephrine and epinephrine, our cortex is secreting cortisol to also kind of activate this overall stress response. This is all, again, in response to this surgical stress, hypotension. This corticotropin releasing hormone triggers release of ACTH, which again triggers the adrenal cortex to increased cortisol. ADH is triggered directly also by surgical stress, and again, hypotension to release vasopressin, which causes water resorption. So again, we want more volume in our blood so we can increase our blood pressure and basically be ready to, again, fight or flight. Again, it's part of the sympathetic response. And then in the pancreas, we actually decrease our insulin and increase glucagon. Again, this is all basically saying that there's multiple mechanisms that make our blood sugar increase because we want to be able to use those stores for a purpose. At the same time, our body's immune system is acting in a very micro level. So this tissue trauma at the site of the surgery, again, much more pronounced in these bigger open cases than a smaller, minimally invasive, small surgical site or even a laparoscopic case, causes cytokine production. So cytokines like interleukin-1, TNF alpha are released from damaged macrophages, so white cells, then cause release of IL-6, which basically activates this acute phase response. So fever, granulocytosis, D-dimer elevation, release of CRP, fibrinogen, alpha-2 microglobulin, all to say that basically when your patients are coming out into PACU, their bodies are activated. So this response can stay more so on the floor. I don't know how many of you guys have done like general med surg as well, but more of this response can be active over the first 24 to 48 hours, but it's still definitely relevant to patients in PACU where they just got through a war. I mean, their bodies are fighting, they're producing these acute phase reactives, they might have a fever. So it can be really hard to parse out what's going on with this patient right now. Are they sick? Do they have an infection? Or is their body just kind of fighting the response to the surgical stress? All that's to say that your body produces a systemic inflammatory response syndrome in response to surgery, SIRS, which again is more pronounced with bigger, more open cases, things like that. At the same time, we have obviously a pain response. Surgery is very painful and it's all kind of interrelated. So it's from a surgical incision, which causes the tissue injury, which causes release of these cytokines, this activation of these pain receptors, nociceptors, so noci meaning kind of pain. The signal is then transmitted via the spinothalamic and spinal reticular tracts, which are pictured over here. And then this all goes in to activate the hypothalamus and the HPA axis, so the hypothalamic pituitary adrenal axis. So again, I've talked about this a lot. This is all interrelated, and secretion of cortisol and catecholamines ensue. So this is the summary, basically. What I'm talking about is it all relates to itself. It all feeds back on itself, and it all really kind of relates to hormones in the end. So here's kind of a general overview of, what the kind of general effects of surgery are by organ system. Again, this is kind of more of the 30,000 square foot view versus the microscopic view that we just kind of went through. Effects on the neurologic system, delirium, right? Is it because of anesthesia or is it because of this kind of inflammation that's going on in the body that might be, inflaming the brain as well? So we're giving people a lot of medications, we being anesthesia. You guys, we're all giving them a lot of medications that can make them very confused and delirious. They're immobile for a certain period of time, whether before they come to surgery or following, depending on what surgery they have. And then again, cortisol production can really do a lot to the brain to make our the higher level thinking a little bit less crisp than it would be normally. Cardiovascular system, we talked a little bit about both the increase in cortisol levels from the adrenal cortex and then the increase in norepinephrine and epinephrine from the adrenal medulla. All of that goes to say that our cardiovascular system is often amped up in this situation. So tachycardia, hypertension being the most common symptoms of that. Pulmonary system, a little bit more general. It depends on what kind of surgery they're having. If they're in a big thoracic case, obviously you're right up against the lungs, in the lungs often. Or in a case where you're near the diaphragm, you can really irritate the lungs quite a bit. But also it's a matter of thinking about if patients intubated versus if they're breathing on their own, various different impacts on the body can ensue. But often we see patients, right? Everyone's always desatting in the PACU. I hear the noises constantly. They're just beep, 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 beep. And a lot of that is because they're just not taking these big breaths, whether that's because they're in a lot of pain or they just were intubated and they were relying on this positive pressure, so breathing the air in versus the negative pressure that usually makes our lungs go kind of up and down. With the GI system, ileus is a huge one, right? So whether it's direct from a colorectal surgery, they're touching the bowel and activating these inhibitory spinal reflexes, or just they got a lot of fluid in the surgery, and so their bowel is really edematous. There are a lot of reasons why patients can have an ileus develop. The renal system, so whether they lost a lot of blood, they didn't have enough kind of fluid resuscitation, or just general arterial or constriction. So again, kind of clamping down on those arteries. There's a lot of reasons for patients to have kidney injuries after surgery. And then kind of the fluid electrolytes is a very general kind of surgery by surgery thing, but the patients are not drinking for a long period of time, particularly if they're a late case. They have a lot of third spacing, basically fluid going from intravascular space to the kind of extravascular space, anywhere that you don't want it to be necessarily. And then surgical exposure. So again, big belly or any other kind of big case, or just losing insensible losses the entire time. So a lot of reasons for them to be dehydrated. Add to that, they have an NG tube. They've got a fistula. They're throwing up a lot. They are often very dehydrated for kind of a number of factors. And then again, I talked about ADH a little bit, resulting in water retention. So decreased urine output for another reason. So again, this is a very general overview, a little bit of the kind of effects of the anesthetics that we use. So we'll do volatile anesthetics, talk a little bit about propofol as well. So on the cardiovascular system, anesthetics actually decrease our systemic vascular resistance and decrease our MAP. So everything I've been talking about before with surgery increases these things. So the anesthetics actually counteract this effect of surgery. That said, when we're giving these anesthetics, at least initially with the induction, no surgery has happened yet. So we're kind of, this is the predominant effect that we're causing on patients. But it also causes heart rate increases. The myocardium, so the muscle of the heart, sensitized to epinephrine. And then actually isoflurane causes coronary vasodilation, more so than the other agents. So sevoflurane, desflurane, halothane is not really used anymore, but those are the common agents I'm talking about here. In terms of the pulmonary system, our tidal volumes are decreased. So the amount of the volume of the breath that we're taking is decreased. Another reason to have atelectasis. But our respiratory rate is increased by these agents. Our functional residual capacity is decreased, and then our stimulation to hypoxemia or hypercarbia. So basically our body, we have too much CO2 or we have too much or too little oxygen, our body will know how to either increase our breathing rate, or it kind of has normal mechanisms to kind of keep that in a normal range. Those are blunted when we're under general anesthesia with these volatile anesthetics. And then in terms of the brain, volatile anesthetics increase our cerebral blood flow and decrease our metabolic use of oxygen. They inhibit autoregulation. So like I said, with our breathing, when we have our CO2 goes up and our body says, I don't want it to be that high, breathe more. With our brain, if it notices that our blood pressure, it's not getting enough perfusion, it will increase the blood pressure. That's all blunted with volatile anesthetics. ICP, intracranial pressure, is increased. Skeletal muscle is relaxed. So we use often paralysis with these patients in addition, but volatile anesthetics actually can have, that's not to the same extent, but can actually help synergistically work with those neuromuscular blockers. The renal system, renal blood flow is decreased. Again, another reason to have AKI, and urine output decreased, predominantly secondarily to blood pressure and cardiac output being decreased. And then interestingly, with the endocrine system, which I've been talking about a lot, volatile anesthetics inhibit, to some extent, ACTH production, inhibit cortisol, inhibit catecholamine production, and inhibit growth hormone. So they can't totally counteract the effects that surgery is causing, but they do kind of blunt that response somewhat. And here's a propofol candle that I thought was kind of fun. So for propofol, a lot of it can be very similar to the volatile anesthetics, but I'll go over it nonetheless. So for our brain, causes hypnosis, causes sedation, causes amnesia, and burst suppression. So basically a really, really deep state of unconsciousness through this agonism. Notably, does not cause analgesia. So that's why we always use other agents, whether it's fentanyl infusion or fentanyl, to act alongside propofol, because that just does not take away the pain at all, really. For our pulmonary system, again, just like the volatile anesthetics, decreased tidal volumes, respiratory depression overall, cardiovascular, just like the volatile anesthetics, decreased blood pressure, so attenuation of that sympathetic drive, decreased contractility, decreased preload, afterload, etc. For GI, anti-nausea, so a lot of patients that will know have a history of post-op nausea vomiting, we'll do a propofol infusion for them so we can make it a little more pleasant for you guys and for people who are in the PACU. There's issues with nausea and vomiting. And actually, one of the articles I had looked at had mentioned that propofol infusion is actually more effective than Zofran for anti-nausea. So, fun fact. And they think it's because it decreases serotonin production in the area postrema, so part of the brain that really can trigger nausea for folks. Endocrine may decrease cortisol, so similarly to the volatile anesthetics, and then no effect on neuromuscular blockade, unlike the volatile anesthetics. Here are some of my sources, and I was told you guys like pictures of dogs. So there's my puppy Bean. She's a 2-year-old Labradoodle. And there's me and my husband from our wedding 2 months ago. Yeah, thank you guys for listening. So basically, overall, surgery causes a lot of stress in the body. That's why patients are in a bad shape when they come out. Anesthesia can blunt a lot of that, but not all of it. And yeah, that's mostly what I got.
See if there's anything in the chat. Where was your wedding? It's cute.
In Maine.
Oh, is that where you're from?
It's where we moved here from. So we moved here from Portland, Maine. If anybody's ever been, it's a really fun city. Definitely recommend. There's direct flights from DTW, really good lobster and other seafood. And I'm from Boston though, originally.
Nice. Yeah, we can start. Is there, I don't know, do you guys have any other questions, comments? Share experience? Anything? And you guys can throw it on the chat.
I have a question. So why don't you run everyone on propofol drip? Is it still effective at preventing post-op nausea vomiting? Is it like a sheer cost thing, or is it too much with the hypotensive?
That's a great point. I think it's a wonderful anesthetic, but I think you're right on the money that a lot of things comes down to money, unfortunately. And then just ease of providing the anesthetic to somebody. So it's much easier for us when we're back there to press a button and turn on volatile anesthetic as opposed to drawing up the propofol, getting it in the pump, getting all the stuff, lined up, which is a very bad reason to not do something.
Mhm.
But that's just the reality of it.
Yeah.
Yeah.
Another thing that I think is really important to answer that is definitely anesthesia. How do we make sure that someone is appropriately anesthetized? And as you know, anesthesia is on a spectrum. We have a level of sedation that might be important for like a colonoscopy, but there might be some awareness of environmental factors. But under general, surgical interventions that require general anesthesia and sedation, we want to make sure people have an appropriate depth of anesthesia. There is no awareness under the surgery. So with volatile anesthetics, we have a lot of studies that have suggested with good data that monitoring their end tidal, what they breathe out, inhalational anesthetic concentration can help give us a strong data point about someone's depth of anesthesia. We don't readily have great markers monitoring propofol. There is some automated things that exist out there looking at blood propofol concentrations. You'll see, I think, an increased fashion in the future here, limited channel frontal EEG, that SED line, or what you may have heard of historically called the VIS, which is looking at just frontal EEG monitoring as another way to help identify people's depth of anesthesia. So you'll probably see SED line more. I'm not sure maybe in the PACU, but if you work in other clinical areas like up at MPU, like our interventional pulmonary procedures where we can't have inhalational anesthetic because it's a shared airway, we need to have an intravenous anesthetic because the pulmonologists are in the airway. So we want as much data as possible to make sure that our patients won't have awareness. It still happens 1 in 3,000, about 1 to 2 to 3,000 cases just in general. And then there's patients that would be a greater risk for that. For example, someone with cardiac pulmonary bypass, someone that's had trauma, you can't just run an anesthetic because they're very hypotensive already. But that's one of the biggest reasons why. But there is a lot of interest in going to IV anesthetics because of environmental concerns. Inhalation anesthetics, particularly nitrous, is terrible for the ozone and the environment. It hangs around for years. And so there is a study that you may actually see some patients getting consented for, if you work in pre-op, to allocate people to a TIVA versus inhalation anesthetic.
The Thrive.
Yeah.
Have you seen and experienced, good, bad? Like, have you had many patients that are involved in that?
I think there's a lot of anecdotal things that we experience, but I think everybody has a bit of a different medical comorbidities and things that will lend them to an anesthetic plan that they tolerate an inhalation anesthetic or be better with an intravenous anesthetic. That's why it's kind of tricky. There's not one way to approach something.
Yeah.
We all have sort of our little parts. That's a great question.
And I've seen already with this trial, I don't know if you guys have been noticing it, but more and more people are saying, oh, this patient was running a pure TIVA. So pure TIVA, which is actually just a TIVA, so total intravenous anesthetic, no volatile anesthetic on board, nothing going through the machine, no sevoflurane, no isoflurane, just propofol infusion going in to keep them asleep. And there's more and more patients that we're doing that for when we have the monitoring, because like Dr. Sagakis said, we don't know if somebody is aware because we are just kind of guessing with, okay, I think this should be enough for them, maybe. Yeah. And then one other thing about propofol, just from a patient that I heard about this morning, for some of our really bigger patients who have a lot of like adipose tissue, propofol gets stored in the fat. And so it can be really, really tricky to have propofol on board. And then all of a sudden the surgery is over and it's just sitting there in the patient's fat. And so it's tricky for room turnover, things like that, patient wake ups. So another reason why sometimes we don't use propofol for, or a propofol infusion, at least for some of these people. But I know that's what I'd want for surgery. So Dr. Ketterball, who's doing the Thrive study, it's like, okay, you're undergoing surgery. Do you want volatile anesthetic or do you want a TIVA? I was like, I want a TIVA. That sounds great. But it's not for everybody.
That was a good breakdown of like the surgical stress, what our bodies go through, and then add medications on top of it, the gases, all that good stuff. So great. We appreciate your time.
Thank you guys.
Thank
for
you.
coming.
Oh, here. So you can just stop recording.
Let me just hit end.
We're hitting.